morning, everyone. Good morning. If everyone can take their seats, we'll be starting session 200, Pediatric Puzzler, Acute Abdominal Pain. Before I introduce our speaker, I have a few announcements. Please remember to turn all your electronic devices to silence mode. If you are attending with a young child, please use discretion, and we ask that you try not to disrupt another's learning experience. The exhibit hall is open today from 9 until 10 and 12:15 to 2:15. This evening from 6 until 7:30 p.m., the SIG showcase is open in Regency 5. We encourage you to visit and learn more about the SIGs. Posters on the move are available today in Regency 5 from 7 a.m. until 7:30 p.m. Presenters will be available for questions from 6 until 7 p.m. this evening. And then on Saturday at 6:30 a.m., there is a Zumba fundraiser. Sign up now at the registration desk. I'd like to introduce our speaker, Michelle Weidekan. She has been a PNP in the Division of Emergency Medicine at Cincinnati Children's since 2002, after she graduated from the PNP program at the University of Cincinnati. Prior to that, she worked as an RN since 1992 on an inpatient unit and then transferred to the emergency department in 1996, where she has been ever since. Michelle was promoted to an APRN program lead in 2008 and now has 15 NPs who work for the division that she supervises. She works in both the main ED and urgent care that are run by the division. She recently completed her Doctor of Nursing practice in May 2015. Please welcome Michelle Weidekan.
Good morning, everyone. Welcome. I'm really shocked at the number of people who get up so early to come to these sometimes. So it's a little intimidating knowing the numbers that we're going to possibly be here this morning. So I hope that everyone has had a great conference so far. I want to thank the NAPNAP Education Committee and the conference committee for allowing me to give this talk. I think for many of us that work with pediatric patients and see patients with abdominal pain, this is a big concern many times, like I don't want to miss anything. So that's what I'm going to try to talk about. I have no financial disclosures. And so the learning objectives for this talk are going to be that I'm going to briefly review the anatomy and physiology of pediatric abdominal pain. And then I'm going to identify some specific acute pediatric abdominal pain emergencies, and then discuss some of the differential diagnosis, testing, and treatments, as well as the management of specific causes of some acute pediatric abdominal pain, and kind of try to pull in some of the current evidence-based practice guidelines or clinical practice guidelines that we have found over the years. But there's not a lot of specific things that we do related to pediatric abdominal pain. It is really based on your institution as well as where your surgeons or where your emergency medicine folks tend to follow. So to start, we're going to go over pathophysiology again. We're going to talk about the various types of pain. We're going to talk about some causes of pain. We're going to go over some evaluation and management of the pain, and then go over several case studies in the end. So there are three main types of pain. There's the visceral pain, somatic or parietal pain, and then referred pain. So the visceral pain generally happens with the intra-abdominal organs. It could be deep or diffuse. It can be described as colicky or crampy, and it's often difficult to localize, which I'm sure many of you find that with your pediatric patients, it's very difficult to localize their pain, especially the younger they are. So for the somatic or the parietal pain, this term refers more to the skin, the muscles, the joints, the bones, and this often occurs in the abdominal wall. It's often at the base of the mesenteries of the diaphragm. It can be described as sharp. They tend to be able to localize this pain better, and then it's often very intense. And then finally, there's referred pain. And referred pain usually is the site distant from the involved organ, and the area or the area where it originates. It may be sharp and localized, and it may be characterized as a distant ache. So the causes of abdominal pain are, the list is like a laundry list long. We could be here all day long talking about all the various types of abdominal pain. In 2003, there was an article that Pollack had written, and he identified that this was in Pediatric Annuals, I believe this is in my references, and he identified that the two most common causes of acute abdominal pain in the US for pediatric patients is first appendicitis and second intussusception. So the focus of my talk is going to talk about various abdominal pain and some of the things that we see, and we're going to go over some of the case studies with a few of the patients that I've seen over the years. But we're going to definitely focus on our two main causes, which we don't want to miss. All right, so when we talk about congenital and anatomic abdominal pain, this could be something like an incarcerated hernia, the intestinal adhesions. This also could be intussusception, maybe malrotation, an ovarian torsion or testicular torsion, again, something you don't want to miss, and then a UPJ obstructions. And the infectious causes could be a cystitis, a UTI, PID, gastroenteritis. All of those things can cause infectious abdominal pain. We also have kids who ingest things. So ingestions of toxic or environmental types of things, such as a foreign body, batteries, button batteries are serious. That's one that we see sometimes. Other weird poisonings like mushroom poisonings or other kind of heavy metal ingestions that kids get into. And then we have trauma. Trauma could be anything from, the MVC that a child is involved in to non-accidental trauma of child abuse. There's tumors, any tumor that could be benign or malignant. We could also see leukemia, patients with lymphoma, a neuroblastoma or Wilms tumor could be causing their abdominal pain. And then there's allergic and inflammatory, where we could see appendicitis, cholecystitis. The eosinophiliac kids can have some abdominal pain. Hemolytic ureic syndrome, HSP, hepatitis, and that list goes on and on as well. Metabolic, something to always keep in mind, is some kids, their first presentation in DKA is abdominal pain. So that's always something to keep in mind in your list of differentials. And then, of course, we have functional abdominal pain, and that could be an all-day presentation in itself as well. So we are not going to talk about functional abdominal pain, but things to think about would be, the depression, Munchausen syndrome, just other weird, psychosomatic causes of pain. And then we have a variety of miscellaneous abdominal pain. We have kids who are considered colic. We see some abdominal migraines along with regular neurologic migraines that get abdominal pain. You could have a patient who is actually has sickle cell disease and they're having abdominal pain. So again, like I said, this list could go on forever and ever, and we could be here all day long. So when you are thinking about your differentials, along with the big list, one of the easiest ways to deal with this is to also think about the age of the child, because certain things happen during certain ages. So if you think about with infants, common causes of abdominal pain for them could be constipation, UTIs, intussusception, the volvulus, an incarcerated hernia. Some kids with Hirschsprung's disease present with abdominal pain. So thinking of specific to the age is really important. Then when you're thinking preschool, school age, the list gets a little bigger, and you're thinking more gastroenteritis, appendicitis, constipation, UTI, intussusception, volvulus can be in there, trauma. Some kids will present with pharyngitis, like strep pharyngitis, and the only complaint they have is fever and abdominal pain. Sickle cell crisis, HSP, the list continues to get bigger. And then as we move into that adolescent phase, that's where we really see a lot larger list of what's more common in the adolescent phase, including the ones that we've already talked about. But then you've got your dysmenorrheas, you've got PID, you've got Mittelschmerz, possibly an ectopic pregnancy, ovarian or testicular torsions, and the list again goes on and on. So now we're going to talk a little bit about clinical evaluation. So history can be very difficult to get in a pediatric patient, as we all know. It can be very limited. The child may not be able to describe the pain. The child may not be able to localize the pain. The symptoms, what came first, parents can't remember, all those things. It can be difficult. And then the other issue is that the physical exam can be difficult in pediatric patients, again, because they don't want to cooperate. So you try to do it on mom's lap, but it's sometimes not easy to get a good abdominal exam on the mother's lap. And then diagnostics, parents always want something done, some test. And so, plain films are great for, just looking at some basic bowel gas, but it's not good for diagnosing something like appendicitis. They're often not very diagnostic. So, and then there's, labs as well as management and trying to figure out. So those are the things we're going to talk a little bit about. So thinking about when did the pain begin? Getting a really good history from the family. What came first, the vomiting or the abdominal pain? Have they had any diarrhea with it? What other associated things did they notice with the belly pain? Is it worse when they're eating? Is it worse when they're lying down? Getting that really good history. And I know some of the other sessions yesterday talked about this as well. And this is so important because sometimes this is the only chance you're going to get that really good history. And then again, how old is your patient? Because that will make a difference related to onset. So again, pain history, location. Is it left upper quadrant pain, where you see more of splenic issues? Is it epigastric, where you're going to see more esophagitis, gastroenteritis, GERD symptoms, pancreatitis? Is it right upper quadrant? I'm giving you clues here on your sites, where you may see more cholecystitis. Sometimes right upper quadrant is a common complaint when you have a pneumonia. Then looking at is it suprapubic? This could be cystitis, dysmenorrhea problems, PID, and then appendicitis. So this is hard because trying to figure out, is it right lower quadrant? Is this related to the appendix? Is this related to the ovaries? What else could be going on here? Pancreatitis often radiates also to the back, so that's something to get a good feel for. Is there pain radiating when you're getting their pain history? And then renal colic, patients can often get some pain that radiates down into their groin. So asking if the pain radiates anywhere can also be really important. Finding out, again, I talked about timing. What is the severity of the pain? How long is the pain lasting? Is it this intermittent colicky pain, or has the pain been continual? And that is so hard sometimes to get from the families, and especially the patient, because depending on their age, they may not be able to describe it for you well. Then asking about precipitating factors, which I talked about a little bit before. So what kind of treatments have they tried at home? Did they try any Tylenol? If the child's had a history of constipation, have they given them any medicine to help with the constipation? And then getting an idea also, does the pain get worse when they're moving around? Is it worse when they're climbing up the stairs? Is it worse if they're jumping up and down? Does it get better after they've had a bowel movement? Does it get better after they vomited? And then following along with associated symptoms, again, we need to really get a good history about the vomit. Is it bilious or not? Generally, pain will proceed. If it's going to be a surgical abdominal pain, it's going to proceed with pain. Pain will come first, then they develop the vomiting. So that's a good indication when you're asking those questions, really trying to get them to remember Was it the pain that started or the vomiting that started first? Finding out about diarrhea, constipation, any fevers at home, any blood in the stool or the vomit, any abdominal distension that the families have noticed on the child, any changes in their level of activity or changes in their feeding patterns is very important as well. So here are some of my pearls and the pearls I've learned over the years working in the Division of Emergency Medicine with pediatric abdominal pain. So any failure to pass flatus or feces, you have to worry about an abdominal obstruction. Any urinary frequency, dysuria, urgency, or malodorous urinary symptoms with UTIs, or with abdominal pain, you gotta worry about UTIs, obviously. Parietal and vaginal discharge with abdominal pain, you gotta worry about PID. So if you have a child, though, that comes in, I have had kids sent in from other hospitals that are more adult-centered, and I can't tell you how many times I've had them sent in for like right-sided abdominal pain. They're worried about appendicitis. And while you're getting the history, you get a good history of the child's had cough and fever, for a couple of days as well. And it ends up being something more like a pneumonia. You can also, have some weird symptoms that happen if they're having any kind of thoracic source, and then they're having this radiating pain into their right side or their left side. Any polyuria or polydipsia, again, getting that really good history to rule out that it's not a child who has diabetes. Asking about joint pain, any rashes, any strange like smoky color to their urine, then you think about HSP. Families that describe mucus red stool, definitely think about intussusception. And then again, bloody diarrhea, thinking more about IBD or some type of enterocolitis. So in females, it's very important to get a really good gynecologic history, and that can be hard. I tend to kind of ask some of the lower key questions in front of the parents, like when did your periods begin, when was your last menstrual period, and then I often walk them to the bathroom myself to get the urine, and that's when I will take my opportunity when mom's not in the room and ask about sexual history. You really have to know how to ask, I've learned over the years, about sexual history, not, are you having or don't ask, are you sexually active? Because if they haven't had sex in the last hour, they'll tell you no. So you have to say, have you ever had sex before? As you're walking to the bathroom, we're having this little conversation because we're gonna have them get a clean catch. And then, but I literally have found that if you don't ask it the right way, they will always tell you no. You never want to ask that question in front of families either, so you try to find a good way to ask them, either whether you ask the parent to leave the room, so that you can ask some other questions and give them some time to talk specifically to you. But there are parents, let me tell you, in the ER that will be like, I'm not leaving the room. I'm not leaving. So you just have to figure out how are you going to do this. So the way I found with some families, if I can tell they're not going to leave the room, that's when I walk them to the bathroom myself and get a good history. And I'll ask all my questions as I'm walking them to the bathroom. So things to think about, though, if they haven't had a period in quite a while and they're having abdominal pain, you do have to worry about pregnancy. If they have a history of multiple partners, vaginal discharge, they've ever been in the ER before for, chlamydia, gonorrhea, any of the STIs, you got to worry about PID. History of PID also increases their risk for ectopic pregnancy. So if they are not having periods, they're having severe abdominal pain, they have a history of PID, that's definitely something we have to worry about. And then, I've noticed a lot of the younger, early menarche patients will have symptoms of middle smirts because they won't be used to this, the changes in their cycle yet. So getting a good past health history is very important, and finding out about previous surgeries, because sometimes they'll be complaining of pain and you'll be thinking it's surgical and they've already had their appendix removed. So you have to go down kind of a different route. Sickle cell anemia, very important to find out if they have that, if they're having any kind of abdominal pain, as well as have they ever had this kind of similar pain in the past. And then other history. So again, this is important to ask family history. Again, I've talked about sickle cell anemia. Is there a family history of sickle cell anemia? Did something fall through the cracks somewhere along the line and they don't know that their child has sickle cell? Any history of cystic fibrosis? Have they had any kind of recent drug use like erythromycin, aspirins, potential lead poisoning? We'll see kids that come in with abdominal pain who have had lead poisoning. We don't see this a lot in Cincinnati, but types of venoms. So have they been bitten by a snake because they're in an area that has lots of snakes with venomous snakes? And getting a good social history too. When I have kind of some weird abdominal pain, it's just that generalized, nothing specific, I definitely ask that psychosocial, have you had a lot of stress at home? How's school going? Who do you live with? Because you can get a lot of information asking those psychosocial questions as well and figure out if there's some psychosocial stress. That kind of goes along with your functional abdominal pains. Okay. So now we're going to talk about the physical exam. Looking at their general appearance, and being that I've worked in the ER for so long, this is the kid that you immediately, as they walk into the room, I'm watching how they're walking, or are they in a wheelchair? So, over the years, that is how I catch their initial general appearance. And then when I walk in the room, I don't touch the child until I've asked some questions anyways, but I'm watching, I'm looking at them. Are they laying on the bed writhing in pain? Are they sitting in mom's lap? Are they, quietly playing? Are they running around the room? And the mom's going, they've got belly pain, and they're literally running circles in the room. So, those kind of things will help you guide where you're gonna go with your history as well as getting your physical exam. Looking at their vital signs very closely, and then getting a really good abdominal examination. There are times when you can't do it without having the parent, kind of lay them in their lap and get a good abdominal good exam. So the other thing I can't stress enough is in females, thinking about their gynecologic history, but also in males doing a testicular exam. There have been times when people have missed and not looked at the testicles, and it was testicular pain, and were having radiating pain up into there. Very, very important. And then considering a rectal exam as well. A rectal exam is important if you're trying to determine, is there a fecal impaction? Is that why? And they haven't been able to pass any stool because they're completely impacted and now they have an obstruction. You can also get a good exam if you're concerned that there may be a retrocecal appendix. If they're having a lot of tenderness when you do the rectal exam in the retrocecal area as well, their appendix may sit in a weird place. When you do that, I go ahead and send it for blood often if the family thinks that they may have seen blood, or when I do the exam, I'll just go ahead and send a stool WIAC. Again, making sure that you get a pelvic exam in female adolescents, especially if you're concerned that it's any kind of GYN concerns. And then, like I mentioned before, getting a good scrotal exam. Okay, so location of pain. We talked about this a little bit before. So whether it's left upper quadrant, epigastric, suprapubic, right upper quadrant, right lower quadrant, really important to determine, because that's going to help guide you where you're going to go with your testing, treatment, and management. If they have rebound tenderness, that's usually concern for some type of surgical abdominal pain, that they have peritonitis, and they may need a surgeon to also look at them. And then doing repeat physical exams, especially serial abdominal exams, when you begin your testing and treatments. We kind of talked about this already. Rectal examination is, again, pretty important. It gives you an idea of the peritoneal irritation, whether there's a mass or a fecal impaction there, what type of stool they have. Is it a hard stool? Is it just some soft, loose stool? And helping to localize some of the pain. So in females, any female that is postmenarchal, that it may be necessary to get a pelvic exam in, because this can help determine PID versus appendicitis versus do they have something ovarian. For PID, if they have cervical motion tenderness, any adnexal tenderness, or like a fullness or mass there, lower abdominal pain, or then you have to also think about, is there a tubular ovarian abscess when you're doing their pelvic exam. If they're still having right lower quadrant pain, many times with these young ladies, we will get, we'll have to move on, and they're not only going to get the pelvic exam, but they're going to probably have to get an ultrasound, but we'll have to have them focus on the right lower quadrant as well. So, and then appendicitis, getting a good idea of whether the pain had migrated to the right side. Did it start epigastric? Have they had any nausea, vomiting, anorexia, or low-grade fever with it? So some concerns related to ovarian torsion. This can mimic a couple other things, but generally you see a patient who comes in with an ovarian torsion that's going to have a stabbing pain. They're going to be complaining of nausea and vomiting. The pain may radiate to the back of to their groin area. They often describe that pain as sudden in onset. It can mimic a renal calculi or kidney stones in some patients. And then if the patient gives you this history of some recent vigorous activity, like they had just run a marathon, or they were doing some other type of like weightlifting or training, definitely something that you worry about. 90% of patients with pelvic pain of females actually present having some type of adnexal mass as well, or adnexal tenderness, and they'll have something that's related to the pelvis area for females. 90% of these patients that come with that present in an ovarian torsion, they will actually have some type of pelvis pain, and they may have an adnexal mass in one of the regions where their torsion is. About 47 to 70% of these patients will present with nausea and vomiting. Only about 2 to 20% present with a fever. And then only about 4% present with like a genital tract, like some bleeding they'll describe. All right. So while you're doing your physical exam, you want to make sure that you think about the different findings and signs. So we're going to talk about a few of them. So rebound tenderness. Rebound is that tenderness that happens when you push and then you let go really quickly. This is a classic sign they consider for appendicitis if you have a patient who has rebound tenderness. Then there's roving sign, and roving sign is when there's pain in the right lower quadrant on palpation of the left lower quadrant. So it's that pain that radiates. So you push on the left lower quadrant and they have radiating pain into the right lower quadrant. Then there's the obturator sign. And the obturator sign is pain on internal rotation of the right hip. And I have some other pictures to show you as we go through this. And then we have the iliopsoas or the psoas sign. And that's pain on extension of the right hip. And then we have McBurney's point, which is where the appendix sits. And then there's also this Murphy sign and Bloomberg sign, which I'm going to show you some pictures of. So really quickly, if you look at what's the psoas sign. So this is an indicator that there's some irritation of the iliopsoas group of the hip flexors in the abdomen. And this test is usually performed by a patient lying supine with their knees extended and then flex their thighs against resistance. If abdominal pain results, it is considered a positive psoas sign. Because of the right iliopsoas muscle lies under the appendix, when the patient is supine, a positive psoas sign could indicate possible appendicitis. So then the obturator sign, I always think learning how to understand all these signs is really helpful, so I hope you don't mind that we're going through this. This is pain when you have passive internal rotation of the flexed thigh. This is an indicator that there's irritation of the obturator internus muscle. If the appendix becomes inflamed and enlarged, the appendix may come into physical contact with this muscle, and then it can be stretched by the physical examination maneuver of the obturator sign, and this causes pain and is evidence to support that there's an inflamed appendix. So this Murphy sign, this is one that is classically performed by asking the patient to breathe out and then palpating below the costal margin of the right side of the mid-clavicular line. This is where the approximate location is of the gallbladder. So if you're concerned about some type of gallbladder cause of their pain, the patient is then instructed to inspire, breathe in, and then normally during inspiration, the abdomen contents are pushed downward as the diaphragm moves down and the lungs expand. And if the patient stops breathing in as the gallbladder is tender and in moving downward, it can come in contact with the examiner's fingers, and the test is considered positive. This is just a description of where McBurney's point is. So if you take your, where the umbilicus is and then go down over the right side of the abdomen, of the 1/3, the distance, and then you find where your anterior superior iliac spine is, kind of that's where your McBurney's point is located. And then we talked about roving sign. This is definitely, they consider this definitely a sign of appendicitis. There's pain in the left lower quadrant as the person's abdomen is palpated, and they end up with more pain on the right side. And then rebound tenderness. And again, this is the pain when you let go very quickly, and the child is describing severe pain as you're letting go very quickly. Now, the interesting one that I found, this Bloomberg sign, when I was doing some of my research for this is definitely an indicative sign of peritonitis. And this is when the abdominal wall is compressed slowly and then rapidly released also. So it's very similar to the rebound tenderness piece. And so many people kind of feel like those are very similar and go hand in hand. Some even say it's basically the same thing. All right, so now we're going to go through testing and treatment. So testing and treatment. This can be difficult because you're thinking, what is the best thing to do? So CBC tends to be something many people obtain, but it's not a great indicator for whether a patient has appendicitis or not. It remains controversial about whether it's really a good lab value to get. Some say that a SED rate may be a better indicator, but if you do obtain a CBC and you have a white blood cell count that's greater than 20,000, they do believe that this is suggested of some type of bacteria or intra-abdominal cause. It is definitely helpful if you think that the abdominal pain is more of an inflammatory process, and we definitely get a SED rate if we are concerned that this is more of an inflammatory process. Getting a beta HCG or a pregnancy test is very important. We generally do that more than serums. When we're talking about being cost effective, beta is much more cost effective. Urine is much more cost effective than getting a serum beta. Getting urinalysis and a urine culture in females. Sometimes getting a urinalysis in males, but it's not really necessary. And then deciding whether a plain film is going to help you or not. And then the latest evidence is actually describing getting ultrasound over CT. And we have moved to that at our hospital. I know not everyone has moved to that, but we have found that we are moving to that direction. So CT is a great study, don't get me wrong, but the patient gets a lot of radiation if you get a CT scan. It is great for diagnosing appendicitis, pancreatitis, intra-abdominal abscesses, mesenteric ischemia, other problems that you wouldn't be able to see through an ultrasound. The sensitivity and specificity of a CT in diagnosing appendicitis is greater than 90%, and it's also great if they're concerned that there's a solid tumor for a patient. But the future is moving towards ultrasound. It is the preferred method in our institution to try to get an ultrasound, even on the obese child. We have ultrasound techs who are amazing at getting ultrasounds. And if you have a really good tech that can get the ultrasound and really try to look well for the appendix, then this is becoming the more preferred way. It is also helpful when you have right upper quadrant pain. Getting an ultrasound for looking for any kind of gallstone problem is also a good exam. And then intussusception, that's the other one that we prefer to start with an ultrasound. So challenges in our pediatric patient. Again, patients frequently present with very early signs of abdominal pain in their clinical course. They come in when the child has had an hour of pain, or they come in and the child's had 2 hours of pain. It's very difficult sometimes to get, because we haven't let it fester long enough, in my opinion, of what's going to go on. Often, appendicitis symptoms can mimic a lot of other conditions. As we went through, thinking about all your differentials, obviously the thing you don't want to miss is appendicitis or intussusception. And the list goes on and on and on. Symptoms can be extremely nonspecific in the pediatric population, and it can be very difficult for children, again, to articulate what's bothering them. So in our institution, one of the things that we use is a pediatric appendicitis score when we have patients who come in and we're really leaning towards appendicitis. And they get a point for various pieces. And then we have this entire algorithm that we have plugged in that we can plug into Epic, which is our EMR system. And it helps us determine whether they're at low risk, moderate risk versus high risk for having appendicitis. So migration of pain gets 1 point, anorexia gets 1 point, nausea and vomiting gets 1 point, right lower quadrant pain gets 2 points, coughing, or pain with coughing, percussion, or with hopping gets more points, and then fever, if somebody happened to send them from an outlying hospital and they got a CBC, or somebody got a CBC somewhere along the line and they have leukocytosis, they get 1 point, and then a shift in their white blood cell count differential. So, greater than 6 on this pediatric appendicitis score is what some people consider to be at risk for appendicitis, and less than 5, or less than or equal to 5, they consider that you observe. So what we've done is taken ours, and we have low, which is usually 3 or lower, and then we have in the middle, which kind of goes up to 6, where it's what we call equivocal, and you're not sure, and then 7 or greater is what we consider to be at a higher risk for possible appendicitis. And so this didn't turn out very well, so we're going to skip over this. So this just talks about low suspicion. Okay, so one of the other things that's become kind of an interesting, controversial concept is the use of analgesia in kids who present with abdominal pain. So the typical teaching was that we shouldn't give them any pain medicine until they've been examined by the surgeon, right? That is beginning to change, and that has been changing over several years. I've seen it change. We still have a hard time. We still, have to argue a little bit for our patients and say, we really think you'll get a better exam if we can give them a little bit of pain medicine. The evidence is strong that randomized controlled trials have been conducted, and they show that morphine analgesia in children with acute abdominal pain provides significant pain reduction, but does not affect the actual examination or the ability to identify those with a surgical condition. So we generally try to encourage the surgeons, especially if they're not going to get down, and we have a child that they're going to come see before we begin any other piece of it because they're on that higher end, that we will give them some type of analgesia, preferably morphine at our institution. We generally give it IV. It's a dose of 0.1 milligrams per kilogram for the first dose, and we try not to give subsequent doses after that unless they're going to be sitting in the ED for a prolonged period before they can go to the OR. But they believe the pain control might help even facilitate them being able to localize the pain even better, or even the origin of pain. So giving some type of pain medicine can help. If we are not leaning towards appendicitis and we believe it's something else, like we believe it could be a kidney stone or gallstones, we will use Toradol if we don't feel that this is going to be an surgical type of abdomen. Because you definitely get pain relief, the child feels better, as well as giving IV fluids, a 20 per kilo bolus in these kids, when we see them, makes a huge difference so that they become at least more comfortable and easier to examine. So indications for a surgical consult. So severe increasing abdominal pain with progressive signs of deterioration needs a surgical consult. Any kind of bile-stained or feculent vomitus usually needs a surgical consult. Involuntary abdominal guarding or rigidity, rebound tenderness, extreme marked abdominal distension and tympany, signs of acute fluid loss or blood loss from the abdomen, you might see with trauma, needs a surgical consult. Any time you suspect that this is any type of surgical case, we want to get a surgical consult. And then any kind of really weird abdominal pain that we cannot determine what the etiology is, and the pain just continues to increase, doesn't improve, we will get a surgical consult and have them come and look at the patient and just help us determine, is it something surgical, or do they believe that this child does not fit their surgical expertise. So, like I told you, we were focusing a little more on appendicitis. We talked a little bit more about it. So what do you do if it's not appendicitis? So definitely go down your other routes of what other types of diseases could it be that's in your list of differentials. Don't forget some of the other things that are out there that cause similar symptoms. What are the next steps? Are the symptoms resolving? What else do you need to do a workup? Do we need to worry about something that's related to the kidneys? Do we need to make sure that we didn't miss something in the ovaries? Do they need to be admitted? Some of these kids with weird abdominal pain that we just cannot determine what it is, we'll admit them for serial abdominal pain or abdominal exams with their abdominal pain and let them be monitored by the pediatric hospitalist on the floor. And then if they feel like it's progressing or moving because they have come in so early in their symptoms, then they can call surgery again to come and observe the patient. Also checking to make sure if you feel like the patient can go home because the child looks well, do they have good follow-up? If you're in primary care, are you going to be able to check in on this patient tomorrow to make sure that they're better? Or does the family feel comfortable calling you if something's getting worse? Making sure if we are seeing them, we communicate very well to the family that at this time, we do not believe that they have a surgical cause, such as appendicitis, for their abdomen, for their abdominal pain. If we don't communicate this well to the family, that at this time we don't see it, they'll be angry if they come back with their abdominal pain 2 days later and then they get worked up again. Making sure that we document well in our EMR records, making sure that we write, at this time there's no signs of appendicitis, and writing why, in the documentation. Because sometimes these kids, the disease progresses and the next day it's more focal and more localized and they have appendicitis. All right, so now we're going to go over some case studies. And these are all actual patients. I can't believe how many I've actually seen over the years of various different types of abdominal pain. And I wanted to add them all in, but I was afraid we'd run out of time. So we're going to go over a few cases. So our first cases, this is a 2-year-old male. His chief complaint is crying. So these kids come to the urgent care and the ED. So the family believes that he's been having this intermittent abdominal pain with his crying, and they describe at least 6 episodes today in the last 24 hours. There's been no vomiting, no diarrhea, and right now when I'm observing him in the room and looking at him, by just general appearance, he's playful, he's active, he's running around the room. Vital signs look good. But what would be my concern? So in a child that describes, a family who describes 6 episodes of intermittent colicky pain, you immediately should be thinking about intussusception. Because these kids can present, then they look great at the moment you see them in the office, but you have got to have a very high suspicion for it. So the classic case of intussusception, it's 3 to 6 years, or 3 to 26 months. Okay, so like 3 months to almost 3 years is our classic presentation, or two definitely, but I've seen it in 2.5-year-olds. colicky, intermittent pain. They're often playful in between, but some families will describe kind of a lethargic or change in their mental status in between the episodes as well. Fussy, maybe not eating, or vomiting as the disease progresses. And then they may, less than 50% of the time, they describe current jelly stools. So one thing, though, also to point out is that you have to remember that sometimes when you see these kids, their only description is that they've been vomiting, especially in that 3-month to 1 year. So it always has to be in the back of your mind. So like I said, less than 50% of the time they'll describe the red stools or the current jelly stools. They may be describing poor PO intake or vomiting, but this is also progression in the illness as well. If they start to look ill, they've got vomiting, they're fussy and irritable in these intermittent colicky periods, and then sometimes they start describing this rare change in their mental status, definitely be thinking about intussusception. They may have some discomfort when you do an abdominal exam as well. But again, I can't stress how much you've got to think about intussusception on this one. So intussusception is, like I talked about before, it is found on ultrasound generally. It occurs in the proximal portion of the intestine where it telescopes into the more distal portion. Our most common ages are 3 months to 1 year, but like I said, I have seen it up as high as 2.5. The intestinal contents are not able to pass. That's what then causes them to start having the bloody mucus stool, and then they also begin with the vomiting. They will often describe this colicky abdominal pain as drawing up of the legs, maybe occurring every 15 to 20 minutes, but they may say it goes on for hours and then it stops. And then the only way to really fix this is through an air contrast enema or surgical interventions. So these kids will generally need IV fluids. They may or may not get an abdominal film. Definitely, if you have a high suspicion, and many times we will jump right to the ultrasound. And then if the ultrasound is positive, they'll get an air contrast enema. Less than 2% of these patients usually have a perforation rate, but sometimes it can reoccur again, so these kids will be observed. They must have an IV before they go to the air contrast enema, which is why we generally put an IV in before they even go to ultrasound. Because a lot of times they'll take, for our hospital, they will actually take them from the ultrasound, if they see it, right on over to do the air contrast enema. They'll call over and say, we saw the intussusception, we're going to take them over to do the air contrast enema. Can you just let the surgeon know? So we let them know. And then there's some questionable thing, again, around a role of pain control in these kids. Generally, these kids, because everything moves so quickly once they diagnose the ultrasound, or diagnose it with ultrasound and they go right to the air contrast enema, their pain is resolved once the intussusception has resolved. But then we need to watch them and make sure it doesn't re-intussuscept. So I've got some pictures for you. So this would be an abdominal x-ray that shows a questionable area of intussusception. My favorite comment is, cannot rule out intussusception when they write their descriptions. So sometimes you can actually palpate this sausage-like mass on the left side, and then a KUB may show an area of an invaginated colon as the mass, and then decreased gas proximal to the hepatic flexor area, which is where the intussusception has occurred. But like I said, we do not rely on the x-ray alone. So this is sort of the general area where you see most intussusceptions occur. It's down in that lower portion of where the small intestines and the cecum kind of come together, and it can invaginate into that area. And then on ultrasound, when they see it, they actually see what's called the bullseye. And again, then they take them, usually for our institution, they take them directly over to do the air contrast enema if they can. And they put small puffs of air introduced into the child's cecum, and the air tracks along the large intestines, and this moves it back out. 95% of the time, the air contrast enema will work. The contraindications are if this child appears to be in shock, maybe has a perforated bowel, or there's any concern of peritonitis, like this has gone on for too long. Recurrence is only about 3 to 11%, but we definitely observe these kids, whether we observe them for a few hours in the ER, which we usually don't have the opportunity to do because we're too busy, so we will usually admit these kids. And this is what an air contrast enema kind of looks like. And then that's sort of a picture of the current jelly stool. Again, less than 50% of the time, families will describe it. If they're getting to that point, it's been going on for a long enough time that they're now having possible ischemia of their bowel. Okay, so case 2. This is a 17-year-old that came in. He was complaining of vomiting. My favorite comment from any 17-year-old boy is, "I think I have food poisoning." They always tell you that. I don't know about you guys, but they always think they have food poisoning. So he was having some abdominal pain as well. He'd been doing a lot more vomiting and abdominal pain and just had a small amount of diarrhea, and this has been going on for 2 days. Now he's got a fever with it, though. So if you think about where things kind of came first, he described that he started with belly pain, then he started with the vomiting, then he had a little bit of diarrhea. But I think I have food poisoning, he kept telling me. I was like, okay. So his physical exam, he definitely was febrile, was kind of ill-appearing when I listened to him. He was a little difficult to examine because he was having more belly pain than I think he was trying to lead on to. He was trying to be tough, but then he didn't really want me to touch his belly at all. He had guarding, he had rebound, he had pain at Bernie's point, and his bowel sounds were extremely quiet and were not active in all 4 sites. Did a testicular exam, it was normal. And so again, thinking about where would your differentials go with this. So, okay, he could maybe have a gastro, but it really wasn't leading down that track. He could have strep, but I didn't really think he had strep because he didn't really describe the sore throat, but he had more like abdominal pain and vomiting, so sometimes you do see that in strep. And then appendicitis was definitely on our list. So diagnostics that we obtained, we did grab a rapid strep that day. I think he did say something about, well, I had a sore throat a few days ago, like prior to this happening. It was really a bizarre description. We did get a CBC and a renal because he looked really dry because he had had so much vomiting. We got an ultrasound of his abdomen, as well as before he could go get his ultrasound, for some reason that day the radiologist wanted an abdominal tube view as well. Well, can you please just send him over? I don't know if they were dragging their feet or what, because they couldn't fit him in. He got some IV fluids. Again, a 20 per kilo bolus is what we generally use. And then we use Zofran a lot for nausea. For patients, he was extremely nauseated. He was retching in the room, so we gave him some Zofran to see if that would at least calm him down and make him feel a little bit better. And then we did get a surgical consult. We felt that he was, that surgery came and looked at him. They felt like he probably did have an appendicitis, but I remember this case specifically. This is one of the ones that I got a surgical consult before we got the ultrasound. And they did well, let's just get the ultrasound. I think he probably has appendicitis, but let's get the ultrasound first. So we did, and then we asked him, well, if we're gonna do this and we're gonna wait, can we please get give him some morphine? So we did. So his diagnosis was appendicitis. He actually described periumbilical pain, and it migrated to his right lower quadrant. He had anorexia when you started talking to him more. He had the low-grade fever. He had been having just little small amounts of emesis, but he really could not keep anything down. He had pain when I asked him if he would jump up and down. He looked like I had 10 heads and said, "Are you serious?" And then he had pain when I tapped at the bottoms of his feet too. So this was a kid that we were concerned, could he have had a rupture as well, just because of how long it had gone on, because he was just getting over that, he was now febrile, his white count was pretty high. So he got, his x-ray showed nonspecific bowel gas pattern. His white count was, he had a white count of 21,000. He had a pretty good shift of 91 segs, and his ANC was over 19,000. His renal was actually normal despite how dry he looked. We did grab a UA just because he's a teenage boy, so you want to make sure that their UA is normal as well. He had a little trace of bacteria. Nothing super concerning. You can see leukocytes in urine when they're having some abdominal, surgical, especially appendicitis. There can be a little bit of whites. And he did go to the OR for appendicitis. His surgery report, I looked it up, it showed a gangrenous appy, so he hadn't quite ruptured yet, but he was on his way. And he got antibiotics before he left to go to the OR. So, and generally all of our kids get some antibiotics before they head to the OR. So I am horrible with mnemonics, but when in doing my reading, there was a mnemonic that kind of came out. So this is something to think about when you're thinking about appendicitis, and it's called Montrell's. And it's migration of pain, anorexia, nausea and vomiting, right lower quadrant tenderness is your T, rebound tenderness, elevated leukocytosis, and then shift to the left for your lab work. All describe kind of a consistent concern for appendicitis. And then I have some other pictures here. So we have very few times can you see an appendical lith. I think it's like less than 20% of the time you can even see the appendical lith. But every once in a while, you'll get an x-ray, because you're not real sure where you're going again. So you get the abdominal film, and there's an appendical lith. So that's what it looks like. And it's when the appendix is dilated. And then on the other side, this is an ultrasound that shows the appendix. So you have your little arrows there that can see like that enlarged area. And it's like a tubular, darker gray area. And then the CT scan, if you go down to the CT, it shows where the dilated appendix is as well. So those are just things to look at if you wanted to know what it looks like. All right, so case study 3. This case just broke my heart, but this is one that I saw and immediately had to think about things other than appendicitis. So this is a 13-month-old female who had a chief complaint of abdominal pain and bruising, and that was what the mom came in for. And then had, some vital signs. There was tachycardia, blood pressure was up, the O2 sats were a little abnormal, like 94, 97%. The mom noticed that the child had a bruise the night before under the left eye, and then she noticed in the morning the child was extremely fussy and noticed some bruising to the abdomen. So she brought the child in. Child had been with mom's old boyfriend the previous day because she needed a sitter when she went to work. So this child, I immediately grabbed an attending when I went in to see this kid because she had her abdomen was extremely full and hard, and she had bruising that I noted right away. She also had bruising to her chest area, and I could see the bruise under her left eye. She was irritable, and she was grunting when I walked in the room, and extremely fussy. And so my question is, are you concerned? Yes, she would be very concerned. So I got the attending involved right away with this patient because I was concerned, and wanted you to think about, so what kind of diagnostics would you begin to order? So right away, we felt that this child, she needed, in that time when I saw this child, we had like more of an acute care area in the ED. Now we just kind of spread patients all over throughout. But we felt like she was going to need some extra monitoring. So we moved her right away. We got a CBC and LFTs. We got PT, PTT, and a type-in screen in case she was going to have to go to the OR. And then we got a head, chest, and abdominal CT. And I know I've talked about before, we don't want to get CTs that much, but in a child that you are concerned about abuse, you need to get a CT. And she also, because of her grunting, we put her on oxygen, and then we gave her a bolus of fluid, and we got the social service worker to come down and talk to mom right away. So her CBC was okay, it wasn't horrible. But her LFTs were definitely elevated. Her AST and her ALT were extremely elevated. So we were just waiting then on the CT results, which showed, again, her differential was normal. She was an O-positive kid. Her head CT was normal, but her abdominal CT was not. She had a grade 2 liver lac. She had a pulmonary contusion. She had a left hemothorax, and she had multiple rib fractures. So this child went straight to the ICU. She did have some drains placed when she got in the ICU. But those are just things to think about. You don't want to think that a kid's coming in with belly pain and fussiness, but as soon as the mom starts saying, I think I've seen some bruising, you got to start worrying about accidental trauma or non-accidental trauma. So, and I'm sorry, because I work in the ED, I don't have an opportunity a lot of times to follow up a lot on what's the next step once they get to the ICU, because we do it as much as we can and package them in the ED, and then we move them on. So. All right, so this is a 13-year-old male, and this is one of the probably the first year I was practicing as an NP in the ED. And he came in with 3 days of abdominal pain. And Mom came in because she was concerned that he had appendicitis, because he was kind of describing some lower groin, right lower quadrant pain. His vital signs were stable. He'd had no vomiting or diarrhea. And then I began to ask him about testicular pain, because I remembered the things in my mind. Okay, I got to ask about testicular pain in boys. So he sits there and he hesitates, and he goes, "My right testicle is swollen." And I was like, "What?" Because he's had 3 days of belly pain, and he never told his mom. And his mom's like, "What?" So we examined his testicle. He had a sideline testicle, significant swelling to discoloration, and that was attributing to his mild lower abdominal pain that Mom was worried about was appendicitis. So again, when we talk about the pearls for any male that comes in with appendicitis, they need a testicular exam. Make sure you ask, have they looked down there? Because some of them haven't. I think they do, but they don't always tell you. Ask the mom if they've told them anything, or the dad that comes in. But always make sure you do a testicle exam. So the window of time is very small. So he, unfortunately, was way outside of the window of time because he had actually had symptoms for 2 to 3 days. So less than 6 hours, they say, if it's truly going to be a testicular torsion, that we can actually save the testicle. Some kids will have some abdominal pain as it progresses, and then they may even complain of nausea and vomiting. So it does mimic appendicitis many times, and that sometimes is why the families come in, because the young boy has not told the parent that his testicles look weird. So again, anytime you have a female or a male with abdominal pain, you got to think about scrotal testicular pain. Suspected torsion, that's automatic. You know, many times it can be something else for some of these boys when they do come in with the actual description of, you know, my testicles are swollen or whatever. It can be something else, but we have to suspect it with belly pain. If they have a unilateral edematous scrotum, or it's a very high high lateral lie, those kids are at a higher risk. These kids need immediate attention if they have a possible testicular torsion. These kids immediately come in. They are made like a high level for our emergency department. They are brought to a room right away. They get a urinalysis. We do an exam, and we get them to ultrasound right away and call urology. All right, case study 5. So this is a 6-year-old boy. He came in with abdominal pain. He was afebrile. He had some kind of diffuse abdominal pain that Mom describes. Started after he had had a bout of vomiting and diarrhea previous 7 days. The vomiting and diarrhea had stopped, and then the belly pain and the vomiting restarted. So one day prior to his admission or his arrival to our ED, she said he began having recurrent symptoms of abdominal pain. It was coming and going in intensity, and he had had a few bouts of non-bilious, non-bloody emesis again. His previous, what sounded like gastroenteritis 7 days prior to that had gone away. The other piece to this, when you get a history, is Mom says none, but then she goes, "Oh, but there was this weird thing that they questioned when he was in utero. He might have had something wrong with his kidney, but we think it resolved, and I never followed up." So you're like, "Oh, okay." So, initially differential diagnoses, because this kid was in exquisite pain, and he wouldn't even lay down on his back. It was really weird. We were thinking, okay, and he was having lower belly pain too. Could he have appendicitis? Does he have a UTI because he has this weird kidney history? We didn't know what it was. That was something missed, after he was missed to follow up. Was it just constipation? Did he have some mesenteric lymphadenitis, which I've seen kids with severe abdominal pain after they've had a bout of gastroenteritis? You see it more in the teenage population for some reason, but we will see mesenteric lymphadenitis. And then I didn't add this one on, but did he have a renal stone? That was another one that was in our list of differentials. So what kinds of things would you consider ordering? So we got a UA and a culture. We got a CBC with diff. We did an abdominal x-ray just because we weren't sure where we were going to go with this kid, and we ordered him an IV fluid bolus, and then we considered giving him some Toradol for his pain. because we didn't really think he was appendicitis, but we were thinking it was going to be something possibly kidney-oriented, but not completely sure. And then we began doing some serial abdominal exams. The Toradol helped. He did relax. He was able to lay down. We give about 0.5 milligrams per kilogram of Toradol to kids. The other thing someone might have considered was to give him a little bit of morphine if we were leaning more towards the appendicitis, but he didn't really fit an appendicitis kind of exam when we got in. So his white count showed 20.3 WBCs, so that's pretty high. His UA was a little odd looking too, small blood, 2+ bacteria, 5 to 9 whites. He's never had a UTI before. He's now 6. That's weird. So, and he's continuing, his pain got a little bit better, but he's continuing to have just diffuse abdominal pain all over. So then we tried to decide, okay, what's our next step? Do we get an ultrasound or do we get an abdominal CT? So for this kid, the day I was working with, the attending I was working with, which let me tell you, we have 40 different attendings and there's 70 different doctors that work for our division. This one chose, let's go down the route of a CT, because this just is really, he just had too much abdominal pain. We wanted to get a good view of many things. So this kid actually had a left hydronephrosis that they found on CT with a possible left UPJ obstruction. So we immediately consulted urology and admitted. So UPJ obstruction usually presents with a history of episodic pain that occurs in the abdomen, can radiate to the front flank area and to the back. And that's why he wouldn't lay down flat, because he was having so much pain. Nausea and vomiting can be present, which he had a little bit. And then the episodes, which Mom had sort of described, was he was having these intermittent periods of severe abdominal pain and cramping and back pain, and then he would get a little better. And usually the episodes will last 30 minutes to several hours. It is more common on the left than it is on the right. It does occur more in boys than it does in girls, 2 to 1. And then it can be bilateral, I guess, in about 10% of the cases. So he was an interesting patient, though. I really feel like what happened with this kid was he was lost to follow-up. So basically it's the narrowing of the junction between the renal pelvis and the ureter. We already sort of talked about this. It can cause some distinct clinical symptoms. It's not supposed to say syndrome, it's supposed to say symptoms, sorry. Severe abdominal pain, nausea, vomiting, and then they can actually have intermittent hydronephrosis. So he was having hydronephrosis when I saw him. These kids generally do need to have some type of surgery done to repair. All right, and we are down to the last one. So this is one that I just want everyone to remember. So, and I've probably shared this before when I've done lectures, but this is my case study 6. So this is a 17-year-old that came in. It was Christmas Eve. She came in with her chief complaint on the track board said abdominal pain. I'm thinking, oh, another female with belly pain, another female adolescent. And I'm thinking where we're going to go down the route here. But when we saw her in the ED, she was having right-sided abdominal pain, and hers was more right upper quadrant, and she was definitely guarding. She was febrile, she was tachycardic, she was really having a lot of chest discomfort, and she had decreased breath sounds throughout. So then I started going down the route, okay, maybe she's got a pneumonia. She's had flu, she's had mono, something else is going on with her. All of her other systems were negative. She had no past medical history, although she did tell me that she had been ill since, off and on since November, after a trip to DC with students. She was a good student. She was, it was the end of the quarter. Finals were supposed to start. I guess it was right before Christmas, because she said finals were starting tomorrow, so it must have been the week before Christmas. She was excited because she had already gotten 2 acceptances to college. She did admit that she had had sexual activity in the past, but she was not sexually active that day. She didn't have any drug use. And so we started going down the route of the differential diagnoses. So pneumonia, definitely, this is one that comes to the top of the list because she's having right upper quadrant pain. She was having some respiratory symptoms. Another one that comes to mind is Fitch-Curtis. So Fitch-Curtis syndrome happens mainly in patients who have had chlamydia or gonorrhea or PID in the past. What happens is the organisms from the chlamydia or the gonorrhea kind of seed into the abdominal wall organism, and it tracks up, and somehow it gets up into the area of the liver, and then it causes this, this colicky pain up near the liver. If it truly is this, it generally will get better on antibiotics. So, and the only true way to diagnose Fitzhugh Curtis is actually through laparoscopy. So that was just on my list of differentials, and I wanted to throw that one out there because I've had people ask about it if they've never heard about it. So, and then gastro kind of hit on the list, and then hepatitis or pancreatitis because of where her location of her pain was, as well as gallstones. So we started with a chest x-ray with this girl since we were thinking higher on the, does she have pneumonia? And what looks wrong on her chest x-ray? So hopefully everyone can see this. So she had a huge heart, huge heart. She had cardiomegaly, never had been diagnosed with anything like that before. I looked at the x-ray with my attending, and he was like, yeah, it's kind of big. Maybe we should call cardiology. I'm like, okay. Because I immediately noted it, and he kind of was like, I think he was really busy. He was sort of blowing me off. I'm like, well, I think we should call cards. He was like, okay, give cards a call. So I called cardiology. They came right down. They did an echo, and they found a very large pericardial effusion. When I went back in to reassess her, too, and now this is my little pearl, too. The first time I just noticed she was tachycardic, I didn't listen for any, like, rubs or clicks or anything like that. She had a significant rub. So then everybody was going back in to listen to her rub. She had a cardiac rub. And the cardiologist was great because they were like, come listen to this. If you've never heard it, you wouldn't know it. So then they were teaching all about cardiac rubs. So she ended up getting admitted to the ICU. They pulled off 370 cc's of serosanguinous fluid from her pericardiocentesis. I looked later because I was so curious with this girl because I was still so new that I wanted to see what did they discover, and they got rheumatology involved, and her final diagnosis was lupus. So it was interesting, but again, you know, not everything is appendicitis. So that's kind of what I wanted you to think. Appendicitis is always at the top of your differentials and very important, but not everything's going to be appendicitis. So you do have to think outside the box and think about other things. So abdominal pain can be extremely challenging. Serial exams, after you do, you know, some type of testing or treatment, going back in, re-examining the abdomen is extremely important. Consider that very broad spectrum of differential diagnoses that are out there related to abdominal pain. I read a lot about abdominal pain. I feel like because we see so much of it, and I'll see some of the weirdest things. Always have a high suspicion of index, though, for appendicitis. Make sure you understand what your local testing plans and characteristics are if you work inpatient or in a hospital. Like, what do they prefer to do? Do they prefer CTs? Do they prefer ultrasounds? Do they need a CPC? Do they not? Because that's important. And then communicating really well to the families and document. So, does anyone have any questions? I always think it's fun to know, like, you see all these people that come in and speak, so I'm a huge Bearcat fan. Bearcats play tomorrow. My husband works for the Bearcats, and then these are my 3 kids. So I think it's always fun to know who you're speaking and getting to know them a little bit better. My oldest daughter there will be a nurse, hopefully in July. She's a senior at the College of Nursing. So, and then my other one is heading to college next year. So.